morning, everybody. We're going to go ahead and get started. If you were here yesterday or listened in, we had presentations from our Department of Medicaid on our managed care program and sort of a history of how we've conducted our payment methodologies. We also heard from NCSL and kind of got a national perspective of what other states are doing. And then had a real good presentation from the Hattiesburg Clinic on how they manage their patient population. Today we're going to be taking a look at what other states do, how they manage their Medicaid population, how they pay it. We have 4 different states, 4 different methodologies. Some are managed care, some are fee-for-service, some are a mixture. So we're going to get started off talking to Barry Cambron, Deputy Commissioner of the Alabama Medicaid Agency. So Barry, are you with us?
I am with you. Can you all hear me?
Yes, we can.
Okay. Well, first of all, thank you for the opportunity to speak with the Mississippi Senate Medicaid Committee on behalf of the Alabama Medicaid Agency. I plan to provide a presentation today, and but hopefully allow plenty of time at the end for you all to ask questions and understand some of the pathways that Alabama made to get to where we are, as well as some of the lessons learned. So I'm going to attempt to share my screen. If you can bear with me for one moment, please. And can everyone see my first slide?
Yes, we can.
Perfect. Okay, if you're okay with it, I'll go ahead and get started.
Go right ahead, Barry.
Thank you. Again, my name is Barry Cambron. I'm Deputy Commissioner for Health Systems here at the Alabama Medicaid Agency. Health Systems is a department that houses the Managed Care Operations Division, the Physicians and Networks Division, the Dental Division and Office of the Medical Director, as well as the Data Analytics Division. I've been with the agency for 7 years now. Prior to that, I spent most of my career with the Kaiser Permanente system. So today, what I'd like to do is give a very brief, high-level overview of Alabama Medicaid, and then really focus on the Alabama Coordinated Health Network, which I'll refer to mostly as the ACHN program, which is Alabama's hybrid managed care model, otherwise known as a PCCME, or Primary Care Case Management Entity. At the end, I'll talk about some of the lessons learned since implementation of this program some 3 years ago. And then, as mentioned, I'll hopefully have about 10 to 15 minutes to answer questions the members have. And at any point, please feel free to interrupt and ask questions. I'll start with an overview of Alabama Medicaid. This chart illustrates the population that we serve, broken down by expenditures and enrollment. And this data is from fiscal year 2020. What we've done here is broken down the population in terms of the disabled and blind, the children population, the aged population, and the other categories, predominantly adult population. So if you start on the left-hand part of the slide, we have grouped our disabled and blind population, which can be any age, and as you all know, most of this eligibility group, if not all, is determined by the Social Security Administration and have automatic Medicaid eligibility. While this group represents less than 25% of our members, actually closer to 20% in 2022, they do represent about 48% of spend in the Alabama Medicaid Agency. And that equates to about $13,000 per member per year. Our child population, age 0 to 18, while it represents more than 50% of the Medicaid population, it represents just under a quarter of our expenses. And these, in Alabama, these are children and families below 141 to 146% of the FPL. And this group annually cost us between $2,700 and $2,800 per year. Our age population are our adults who live in poverty, a lot of the dual eligible population and nursing home population. Almost all of this group is also covered by Medicare. They represent less than 10% of our membership and 17%, 18% of our expenditures, and they cost about $10,800 per member per year. And then we just grouped several other aid categories in the other adult categories, and this is typically the age 19 plus. This group includes many aid categories, but predominantly our pregnant, sober women population, who right now the coverage ends 2 months postpartum, our parent caretakers, and then our Plan First or family planning recipients. And this group is relatively low in terms of per member per year at $3,800 per month. So they represent about 17% of our membership and 11% of our expenditures. But before I move on to the next slide, I would note, and we're going to cover this in a few slides, the overall enrollment for Alabama as of September of 2022 has now exceeded 1.3 million. And I'm going to show a chart that's probably similar to charts that you've seen in Mississippi that shows the percentage, the steep growth, the percentage increase that we have seen since March of 2020, the beginning of the outset of the pandemic. So right now we have about 1.3 million Medicaid recipients and have just exceeded in FY 2022 $8 billion spent on benefits. So this slide shows how we spent those dollars in FY 2021. This chart depicts the major benefit categories in Medicaid, and as you can see on the right-hand side of the chart, over 50% of our benefits dollars are spent on hospital care and nursing home care. Hospital care includes inpatient, outpatient, and we actually include federally qualified health plans in this category. They represent more than 37% of our overall spend. Nursing homes, we spend about $1 billion per year. That represents 13%. Pharmacy comes in at just under $1 billion, although in 2022, I think we might have exceeded that. That's 12%. Physicians represent another 8%. Mental health services are 7%. The majority of the state share is actually funded by our Department of Mental Health, a sister agency. And then we have other categories like other plus alternative care. This includes programs like dental, a lot of our long-term care waivers, targeted case management, as well as third-party administration. That represents another 18%. And I would note that our administrative costs in any given year, it varies between 3 and 4%. So we operate on a relatively lean administration budget. And so in FY21, our total expenditures were $7.7 billion, but in FY22, which just closed out our fiscal year in September 30, our total expenditures have now exceeded $8 billion. This next chart shows the source of our funds. Similar to Mississippi, Alabama has a very high proportion of federal funding, like a lot of other sister southern states. In any given year, it typically ranges from 72% to 73%. But due to the public health emergency and the associated maintenance of effort requirements, we, like every other state, is getting a 6.2% enhanced FMAP. So in fiscal year 21, of our $7 billion plus budget, about 77% was used with federal funds. It's actually probably closer to 78%. The other 23% of state funds, about $1.7 billion, roughly 9% was from our general fund at $650 million. Other state share sources accounted for the rest, and other state share sources includes provider assessments, which is predominantly hospitals and nursing homes, as well as intergovernmental transfers, interagency transfers, if you will. And there are some certified public expenditures in that as well. But since fiscal 2020, we have remained at about that 78% FMAP rate during the PHE. This is the chart that I referenced earlier. This shows what has happened to Alabama Medicaid's enrollment since the outset of the pandemic. In October of 19 through March of 20, our membership had remained steady at about 1,050,000 recipients. And for the most part, since 2016, 2015, we had been fairly flat from the standpoint of overall recipient growth. We had seen maybe a 1 to 2% growth per year, but our projections entering the pandemic year were that we would probably remain at 1,050,000 to 1,060,000 from a budget perspective. And as you can see, when the pandemic started and the state chose to get the enhanced FMAP, we entered, like every other state, the maintenance of effort requirements, which basically means, and I think most of you know this, basically means that no recipient can be taken off of our rolls unless they ask to be taken off, they are deceased, or they move out of state. So beginning in March of 20, and the growth has been fairly steady. It's been between 7,000 and 8,000 recipients a year. As of September 2020, we are now at 1.3 million recipients. As of today, I think most of you are probably keeping an eye out for this as well. We have not heard from the Biden administration on a potential 60-day notice for the end of the public health emergency. We anticipate it maybe today, maybe Monday. If they do give the 60-day notice, which will be sent to the governors of each state, we anticipate, and we have anticipated in Alabama from a budgeting standpoint, that indeed it will end in January, at which point we would begin the process of unwinding those recipients over the course of 12 months. As you all know, there's a lot of uncertainty still associated with that. We don't know when the PHE is going to end. There's uncertainty with some of the current congressional races. But for the purposes of our budgeting process, we are assuming the end of January, we'll be at 1.33 million recipients over a 12-month period. There's a lot of uncertainty there, but we think that we will ultimately go back down by the first part of 24 to about 1.1 million to 1.2 million recipients. I'll end with the Alabama overview with a percent of population eligible by county. We have 67 counties in our state, and I would imagine Mississippi probably has some similar color-coded charts like this or maps like this. And this just shows the highest percentage of eligibles in each county of the population that is Medicaid eligible. And if you look at the dark shaded counties in the middle of the map here, those are predominantly counties that are, they have a high African-American percent of their population, and they tend to be lower income, and not unexpectedly, in those counties, you see about half of the population eligible for Medicaid. And in most of those counties, about 80 to 90% of the children in those counties are Medicaid eligible. Versus, if you look at the bottom of the state, Baldwin County, which is on the coast, the top of the state, which is Madison County, the Huntsville area, those counties tend to be higher per capita income, and as such, a much lower percentage of the population eligible for Medicaid. So the population eligible by county in our 67 counties swings fairly significantly, with the low being about 13% in Shelby County, a high being 51% in Wilcox County. So that's a high-level overview of Alabama Medicaid. Now we'll switch to our model of what we're calling a hybrid managed care program in the state, which is the Alabama Coordinated Health Network, or ACHN. So I will start with some background and context for the members to illustrate, at least since over the last 10 years, what our pathway has been to get to the point where we are now with our current model, which is a PCCME model. Our agency is just over 50 years old now. But the planning for what was going to be full-blown managed care, otherwise known as regional care organizations or RCOs in the state, planning earnestly began in 2012 for this. At the time, our Governor Robert Bentley, established a Medicaid Advisory Commission, probably not dissimilar to what you all are doing right now, to review other states and to propose recommendations to curb the growth trajectory of the Medicaid program, but also to improve the quality outcomes in our state and the types of care that our recipients receive. In 2013, a law mandated that Alabama Medicaid begin our transformation to full managed care. through an 1115 waiver to implement RCOs, or regional care organizations. So in 2013, a 4-year planning and implementation effort began. In fiscal year 17, when the program was ultimately supposed to launch, much like today, the state Medicaid covered about 50% of the children statewide, covered about more than half the deliveries, accounted for more than 26% of the state's population, which is still the case. And at that time, our program expenditures had gone from 4.4 billion in 2008 to 6.5 billion in 2017. And as mentioned earlier, we are now at the $8 billion level. But in July of 2017, just months before implementation, due in large part to a lot of factors, but predominantly new federal regulations, funding concerns from both the state and national level, as well as an intent to develop more flexibility in the state, ultimately the state and the agency ended RCO implementation literally months before it was to launch in October of 2017. So what happened at that point was Alabama Medicaid pivoted. We use the word pivoted a lot during that time, from essentially a full managed care model to where we are now, which is a hybrid model, or PCCME model. And so the RCO pivot plan, as we called it at the time, was an expansion on the care coordination principles and an expansion on our care coordination model, but also incorporating lessons learned through full MCO implementation, including incentivizing for outcomes and cost effectiveness. Additionally, providers in the state had embraced care coordination and supported this model, which is very important. Provider engagement and feedback obviously is critical for any implementation, but more so for this than any other initiative in recent history. And Alabama had a long history of care coordination in the state, beginning in the late 90s, early 2000s. We had a maternity contractor program through a 1915B, which provided global services from the prenatal period to birth to postpartum. We had a medical home program called Patient First, which was a primary care / case management medical home program. And then we had expanded statewide in 2015 with a health home program. And finally, we had a longstanding family planning waiver called Plan First, which was an 1115 waiver provided for the most part by the Department of Public Health. So the decision to pivot and switch to this model effectively was based on these principles that we had essentially embraced for about 2 decades almost. So where we landed was this hybrid model, or the primary care case management entity model, again, PCCME model. And this chart just visually shows where PCCMEs fall between traditional fee-for-service and full risk-based managed care. Alabama has been a traditional fee-for-service state since the outset of the program in the 70s. And this pivot to the ACHN program allowed us to ultimately land in this hybrid model, or the PCCME approach. And again, this program is administered through a 1915B waiver, and it expands on our strengths, again, rooted in care coordination, but in a model that we think providers around the state, ranging from hospitals to primary care physicians, OBGYNs, and specialists, could embrace and accept, and also allow for incentivizing for health outcomes, which was very important to the agency. So the new direction was called Alabama Coordinated Health Networks. And what it is a statewide single care coordination delivery system that combines the former programs that I mentioned earlier around maternity contractors, health homes, patient medical homes, and our Plan First, or family planning waiver, which included embedded case management with our population. 2 years of planning went into this, lots of correspondence with CMS, and ultimately we began in October 1, 2019. So the program is now in its 4th year, but it was started 3 years ago. And the original model for the delivery of care coordination was face-to-face. However, only 5 months into the program, due to the COVID-19 pandemic and the start of the PHE, the ACHNs and the agency made the decision to transition to a telephonic-only model of care coordination because a lot of hospitals, a lot of provider offices essentially closed down and shut out non-essential staff, which included the ACHN care coordinators. There's other reasons, but that was a predominant reason, excuse me. I will say that effective October 1 of this year, although we're still in the PHE, we have transitioned the ACHNs back into what we're calling normal operations with what we're calling a hybrid model of care coordination, where for the most part, we are going almost all back to face-to-face care coordination, but we are allowing telephonic care coordination for some of the general population. And so we'll talk about some of the care coordination services on the next slide. But effectively, what the program was designed to do was to replace the siloed programs that I've mentioned earlier, the health homes, the medical homes. It was to replace those silos and do one current coordination effort. And these coordination services are provided by the regional PCCMEs or the ACHN networks. There are 7 defined regions in the state, consisting of independent boards, half of the boards being comprised by primary care physicians. So in terms of the payment methodology and the reimbursement methodology, it was largely a significant switch from our traditional payments for care coordination, as well as fee-for-service payments for that matter. And the principles that we aligned the program around were payment for activity, that is case management activity, and having the ability to earn an incentive or bonus based on the attainment of quality outcomes, as well as hitting certain cost-effective targets. And also, it was a cap budget. Cap budget meaning we wanted this to be budget neutral from the standpoint of this was not an incremental spend for the agency. It was essentially replacing the spend on the former programs and some physician fee-for-service programs with a new budget that would be effectively capped. So the major shift being the payment for activity and the incentive. Traditionally, our primary care providers have been paid fee-for-service, and for the most part still are. But these other entities providing care coordination were largely paid on a PMPM basis, and they had assigned recipients. There was not a payment necessarily for case management activity performed or rendered, nor was there a bonus system in place. So what this ultimately switched to was a combination of and this is for the ACHNs, the entities themselves, a PMPM, which represented a fairly small portion of the total payment, but it was designed to cover some of the quality improvement projects that we'll talk about later and some general and administrative fixed costs that are associated with running these programs. But for the most part, the majority of these dollars from a payment perspective switch to specific care coordination services rendered. And there are about 17 different types of payments for the general population, maternity population, and family planning population based on the complexity of the case management service and the level of activity, the time spent per recipient during a month on recipients receiving care. And then finally, we also reserved in our funding an incentive payment that is made at the end of each fiscal year to the ACHNs based on their attainment of quality metrics. And I'll show you a chart later that kind of goes into a little detail, but it's basically 14 quality measures that are based on CMS adult and child core sets and is based on progress towards hitting a 5-year benchmark. So it's payment for activity and payment for incentives for the most part is how we design the program. The regions themselves, as mentioned earlier, there are 7 regions across the state. Right now, of our 1.3 million Medicaid recipients, more than 80%, or about 1 million, are assigned to the ACHN entities across the state. For the most part, the population is equally distributed within each of the regions. We do have higher distributions in Jefferson Shelby, which is the Birmingham metro market, as well as the Gulf Coast region at the bottom of the map, which is predominantly the Mobile market. But for the most part, we tried to base these regions on existing patterns of care and referral processes, access to care, as well as ensuring financial viability. So we looked at different numbers ranging from three regions across the state to 12, but we felt that 7 would still provide regional variation specific to the local care in that market, but also provide scale for the ACHNs to be financially stable. And so this million plus recipients population that's assigned consists of the general population, which is predominantly women and children, adult parent caregivers, as well as our some of our maternity population. We also target about 95% of all maternity care eligible recipients, and then finally our family planning or Plan First waiver population, which are women aged 19 to 55 and men over the age of 21 that qualify for procedures like vasectomies, as an example. So what do the care coordination services entail? First, the referrals can be requested by anyone, and this includes providers, recipients, hospitals, other community resources. Now that we are back to face-to-face, these services can be provided ideally in the setting of the recipient's choice. The concept being we want to meet the recipient where they are. And these include provider offices, county health departments, hospitals, including the maternity wards at hospitals, the ACHN local offices, or basically any public location or recipient's home. That was one of the core principles of the model. And so what some of the services entail are an initial screening and assessment, psychosocial assessment of the recipient's needs, assistance in helping the recipients obtain transportation or Medicaid application assistance, helping the recipients with appointments or reminding the recipients of their appointments, coordination and facilitation of referrals to other specialists as an example, and really education and assistance with medication and treatment plans and the most appropriate setting for these recipients, be it the office, the ER, or even in the home. And then ultimately providing the recipients with community resource guides and helping them get the appropriate community resources such as food assistance or transportation assistance. We have a very specific set of services for the maternity population, and I'm going to speed up a little bit so I can have time for questions. The maternity population, they also get eligibility assistance, but a critical first prenatal encounter, which what we call a comprehensive psychosocial assessment. And the recipients are screened for substance abuse, brief interventions, and referrals to treatment if necessary. We've also included additional prenatal encounters, inpatient delivery encounters, and in-home postpartum encounters, particularly for the high-risk maternity population. This slide just shows some of the relationships that the ACHNs have with community-based organizations that I mentioned earlier, such as those that can provide support for transportation, food assistance, and other community resources, such as faith-based organizations and substance use disorder. At the heart of the program is quality. And the ACHN ultimately is a quality improvement program. The goal of the program has 3 primary health outcomes where we are targeting improvement. And that's prevention of childhood and adult obesity, really, but prevention of obesity, improvement in infant and maternal mortality, and substance use disorder. And so we judge the progress of this program long term. That is, how are we moving the needle in the state, because the Medicaid population is such a significant portion, with these 3 primary health outcomes, because we rank near the last of the nation in all 3. So quality improvement projects are one component, and then the quality improvement incentives are the other. The quality improvement projects are basically all designed to revolve around the 3 outcomes. Every year, the ACHN must submit to the agency for approval a description of these projects, which it has chosen to address these three topics. We also contract with an external quality review organization that helps us evaluate each QIP for each ACHN. We have quarterly calls with the EQRO, and the EQRO provides an annual evaluation on the implementation. And there's a CMS requirement that this evaluation is published on the agency's website. So you can feel free to go to the Alabama Medicaid website. You can see the year 2 evaluation of the ACHN's performance on these quality improvement projects. I mentioned earlier that was one component of our improvement program. The other is around incentives. And so again, the incentives for both the ACHN as well as our primary care physicians all revolve around obesity, infant maternal mortality, and substance use disorder. So we chose in planning 15 different quality measures that are from the adult and child core sets from CMS. And these include well child visits, adult and adolescent BMI, live birth weights, access to care at different age ranges, live birth weights, timeliness of prenatal and postpartum care, and initiation of engagement in alcohol. We also likewise, for our participating primary care physicians, chose similar measures by which they are incented to hit certain targets. We'll not spend a lot of time on this slide, but this is a chart that ultimately is used to define how the ACHNs will earn their incentive. So I mentioned earlier there's actually 14 measures, and at the outset of the program, for each of these measures, there was a baseline, which was 2013 to 2017, basically a 5-year baseline. And we set a benchmark, and in most cases, this benchmark was set at the 50th percentile or even lower because Alabama ranked so close to the bottom in a lot of these metrics. And ultimately, this benchmark was a 5-year target. And on an annual basis, if the ACHNs make progress towards that target based on an actuarial algorithm, they qualify for a bonus. And so all this chart shows is kind of a mixed bag of success. The green represents the quality measures where they hit the targets for year 2 of the program, which just ended. The pink or salmon colors show where they missed the mark and they did not receive an incentive. And so as you can see, all of the ACHNs for the most part fared well with body mass index measurements as well as asthma medication ratios. Likewise, they showed significant improvements with timeliness of prenatal care. But there is significant room for improvement with access to primary care as well as well child screenings and initiation and engagement for treatment of alcohol and other disorders. And we do know that COVID played a major impact in that, but we still stayed firm with respect to keeping our targets the same. The final component of our incentive for the program is with respect to bonuses that we pay to participating primary care physicians. We have about 1,000 plus primary care physicians that participate in the ACHN program. It's at the group level, so there's about 500 groups, which represents about 1,100 or so primary care physicians. So it's a multi-tiered payment model, but ultimately the bonus payment is based on a pool that is set aside as part of keeping the program budget neutral. So this $15 million pool that is set aside for every fiscal year is distributed in quarterly increments. And the physician pool basically is paid to the physicians on their attainment of quality measures, as well as hitting certain risk-adjusted cost-effectiveness scores. And that is based on a risk-adjusted model that essentially compares their PMPMs to their peers across the state. Additionally, if they participate with the ACHN program, they get an enhanced fee-for-service rate for certain procedure codes. Basically, what's called evaluation and management codes or office visits. We identified 15 visits that are preventative in nature, and we basically set them at commercial rates. Basically, we have a large payer in the state, commercial payer, and we tried to set the rates at that level. So if they participate with the ACHN program, they get essentially a commercial rate. Additionally, at the end of each quarter, they qualify for a bonus, which is based for the most part half on quality and half on cost effectiveness. These are the quality measures for primary care physicians. Again, similar to the ACHNs, they are separated into child and adults. So they also have targets to hit for well child visits, adolescent well care visits, and certain immunization combinations. Adult measures are based on antidepressant medication management, A1C testing, chlamydia screening for women ages 21 to 24. Additionally, we have OBGYNs that are incented based on performing prenatal visits in the first trimester, as well as postnatal or postpartum visits in days 21 to 56 postpartum. So we've incented both primary care physicians and OBGYN physicians in the state to help move the needle on some of those outcomes that I mentioned earlier. So, the lessons learned from this program, and then I'll end on one slide and open it up for maybe 10 minutes of questions. So we now finished year 3 of the program, as I mentioned earlier. We're moving into year 4. Year 5 will be the last year of the program before we go into procurement mode again. And so we're using a lot of these lessons to develop the new procurement, the new RFP for fiscal year 25. But we think that the primary strengths of what we developed with this hybrid model is that it did indeed create a single care coordination system that replaced silos and linked patients to providers and community resources. It did streamline the care coordination network within the state, and it utilized the existing health home providers, the existing medical homes with primary care providers. They all chose to participate in this program. The quality improvement interventions are linked to standardized quality measures for CMS, and they are set on regional rates. So we feel that the quality improvement targets are fair. There's low bars to hit in certain cases, but as long as there's progress made, they have the ability to earn an incentive. Again, they can earn these incentives through the attainment of these quality measures. By separating the state into 7 regions, we've allowed for region-focused interventions. Much like Alabama, I'm sure Mississippi has certain pockets of the state that have different health needs. For example, the northwest part of Alabama has a significantly higher incident of opioid and substance use disorder relative to the rest of the state. In some of the lower income counties with a high distribution of African American population, there are different needs. And a recent example is sickle cell. We have increased our budget to have focused interventions on the sickle cell population, and so this model that we have allows for more regional focused interventions for both the case management as well as the quality improvement project. And even within those regions, it's provided opportunities for local collaborations to focus on issues within regions. So we have some regions with 2 counties, we have some regions with 12 counties. And so there are certain county-specific initiatives, so it actually allows them to go down to the local level, even the zip code level. And then finally, this is allowed for information sharing and partnership with providers within a region, because providers that participate, they have to sign, obviously, a provider enrollment agreement with the agency. They also have to sign an agreement with each ACHN. And with that comes certain requirements. Medical management meetings, multidisciplinary care meetings, and that enables them to get that higher rate and potentially qualify for a bonus. So we think those are some of the strengths of the program as we look back from 3 years ago. With it comes several opportunities for improvement. One of which is to continue to look at our incentives and make sure that we're incenting the right behaviors. So we think that we will have the ability to modify incentives and payment structure to drive quality outcomes for the population. An example of that is we're looking at potentially raising the incentive rates for certain maternity outcomes while potentially lowering some of the case management encounters, because we feel that we don't have enough maternity recipients targeted, and we're still lagging in some of those metrics. So, I meant increasing the payment for case management for some of the maternity population as well as the incentive. Likewise, maybe lowering that for some of the general population, because right now, based on the payment structure, that is where they're focusing their efforts. Another area of opportunity is to better define risk stratification methodology and align the intensity of care coordination. And by that I mean, the agency did not provide a defined risk stratification methodology for how they would stratify their general population, maternity population, and provide specific guidance around high risk equals high intensity. As such, it has led to, I guess, inconsistencies across the state. And so I think the first 2 are the primary opportunities, which is to modify the incentives and payment for the types of intensity of the case management that we would like to see, as well as truly have a standardized approach to our risk stratification. And the other few examples I would also mention is, again, standardize some of the performance indicators for quality improvement projects, make them more population-based. What we have seen is for some of the quality improvement projects, while they are beneficial in nature, they are targeting relatively small populations. And so what we're looking for now is maybe more of a population health outcome-based focus, which includes hiring key staff that have experience with population health, among other things. And then ultimately continue to integrate more evidence-based practices into the program. There's lots of care coordination models out there and case management models, and we have left that essentially at the discretion of the ACHNs, and that has been a mixed bag of success. And so where I would say the agency and the ACHNs can improve is to continue to look at best practices nationwide and with our sister states, and incorporate more evidence-based practices into the care coordination efforts. So that concludes my presentation. I know at this point I have, I think, maybe 5 to 10 minutes for questions, and I will gladly entertain them now. And if I can't cover all of them now, my contact information is up here. Please don't hesitate to reach me directly at my number or email address. And at this time, I'll take questions.
Thank you, Barry. That was a very impressive presentation.
Thank
I've
you.
got a few questions for you. Sure. You talked about at the very beginning, and I just want to clarify on your postpartum care for women. Have you extended that time period to 12 months? Or are you in the process of that?
Yes, sir. Good question. We submitted a SPA to CMS in July for approval to extend our postpartum care from 2 to 12 months. At this point, we are still waiting to hear back from CMS. We think it's primarily due to there's a backlog of other states that are also seeking approval. Additionally, we are expanding our dental benefits to the adult maternity population. And so at issue with CMS is whether that's going to be 2 months or 12 months. We don't necessarily view it as tied to each other, but I think CMS is trying to clarify a few things and give us guidance. But right now we're waiting on approval, but we are seeking approval for an extension of our postpartum period from 2 months to 12 months.
Thank you. On your Medicaid enrollment, yeah, we had similar trend, through the PHE, and I think we're probably around 850,000 or so right now enrolled. But while the membership has increased, the utilization has not increased. Have you seen the same?
Absolutely. In fact, our analytics division just finalized an analysis that looked at the PMPM of what we're calling the MOE population. That is a population that's still eligible due to that requirement. Utilization is significantly below that of our overall population. It's about anywhere from, depending upon the eligibility group, a third to a quarter of a traditional PMPM. That said, I mentioned we just finished fiscal year 22. We saw a significant increase in utilization, as did other states, based on some recent research that I saw. Our overall utilization, just based on simple percentage of claims, increased by 13%, not necessarily due to the MOE population, but that MOE population was incremental. But we feel that there was pent-up demand, if you will, in the population. There was a lot of recipients who were probably foregoing screenings, as an example. Also, more provider offices started to open back up really full time in fiscal year 22. So I think Mississippi, like most other states, and definitely Alabama, saw an increase in that FY22 in overall utilization and subsequent benefit costs. But to your point, we likewise, like Mississippi, just simply have not seen the utilization in this population. And I think in large part is due to some of these recipients don't know that they're still eligible. We know that for a fact anecdotally. But for our maternity population that typically would have ended, we know that that is the case. And in fact, we sent out a reminder to that population about a year ago.
I think you're correct on the awareness issue. I think we've experienced the same over here. On your ACHNs, you've got 7 of them, but one of them only has 2 counties. Why only 2 counties?
That is Jefferson County and Shelby County, and that is basically the metro area for Birmingham. And so those particular counties in our state, they account for more than 10% of the Medicaid population. So when we were essentially drawing these maps, we looked at like I mentioned earlier, anywhere from 2 to 3 regions up to 10 to 12 regions, and ultimately it was the main principle is that we wanted each of the regions to be financially viable, number one. And so each region initially started off at about 100,000 to 110,000 per region. So we had about 750,000 recipients when the program started. Obviously, we're at 1 million now due to the MOE. So that is based primarily on the population density, but also existing patterns of care. Those recipients, we looked at where recipients go for their primary and hospital care and OB care. And so a lot of factors went into it, but it was basically distribution of population, which is why Jefferson County and Shelby County are comprise what is called the mid-state district.
All right, thank you. Walk me through, pretend I'm a family practice physician, and walk me through how do I get enrolled? How do I get the patients assigned? Because unlike, are there any PAs required? Because unlike, when you're dealing with the MCO, you've got all these steps to go through. I'm just kind of curious as to how that's managed on your end.
Yes, sir, and that's a great question. I wish I could have spent a little bit more time on that, but we have a lot of resources on the ACHN program on our website, which I would encourage you to go to if you have additional questions, and also reach out to me. But the participating PCPs, the 1,000+ PCPs that I mentioned earlier, to be able to participate in the ACHN program, which again qualifies them for higher fee-for-service rates as well as entitles them a potential bonus if they meet metrics. It represented a fairly significant shift from the former medical home program in which recipients were assigned. We had an assignment process where they had a panel. The agency and the University of Alabama Analytics Division had an algorithm to assign recipients on a monthly basis, and back then the PCPs were paid on a monthly basis. With the advent of the ACHN program, we moved to an attribution model. So all providers in the state, not even those that are participating with ACHN, though most are, they are now attributed recipients. And our attribution methodology is effectively based on recency of visits, frequency of visits, certain preventative procedure codes, as well as certain preventative medications. And so every quarter, we attribute recipients at the group level. So you could be Dr. Smith, and you could be in a practice with 7 other providers. The recipients are going to be attributed to your group, and your group will be the one that is ultimately paid the bonus based on their performance. So recipients are now attributed, not assigned. That was I would say that took a lot of education and change management with physicians initially, but I think they're accepting of that now, particularly because we have a reconsideration process every quarter whereby if they feel that they're not appropriately attributed recipients, they can appeal that to the agency. And we really haven't had a lot of pushback on that. I think it's a fair system. So to participate, you have to have an agreement, obviously, with the Medicaid agency, but you also have to have an agreement with the participating ACHN. So as long as you have an agreement with any of the ACHNs, regardless of what region your group is practicing, you can be practicing in multiple regions, but as long as you have an agreement with the agency, as well as with an ACHN, and meet certain participation agreements, you are able to qualify for the program and therefore have the ability to earn the bonus and get paid the higher rate. The other lesson learned that I did not mention is better enforcement of the participation agreements. In that there are 4 medical management meetings, there are quarterly medical management meetings that the ACHNs hold for their providers. To keep your agreement, we have mandated that providers attend 3 of those 4 meetings. We allowed some flexibilities in that during the COVID period, but now we are executing our ability and the ACHN's ability to terminate those agreements if providers don't meet the participation agreements. So there's a few administrative things that providers have to do, such as the medical management meetings and participation in multidisciplinary care team meetings for high-risk members. But that's ultimately the basis of it, is having 2 agreements, meeting the participation agreements, and having recipients assigned to you, or attributed to you, which plays a part in your bonus determination.
Thank you. And the last question for me is, I think I understood you to say that your rates are based upon commercial rates and not Medicare?
Yes, sir. So for the 15 E&M codes, the evaluation and management codes, these are your typical office visits. So you go to your doctor, you spend 15 to 20 minutes. That might be what's called a 99214 procedure code. We have we have different rate structures. We have a base rate. We have a rural rate, which is typically $1 more. But what this enhanced rate, the ACHN enhanced rate, does is pull these 15 E&M codes up to a commercial rate, which is essentially comparable to that of the largest insurer in the state, Blue Cross Blue Shield of Alabama. And it is, we have not looked at those rates in comparison to Medicare, but at least in 2020, they were slightly higher than Medicare. But we wanted to provide enough of an incentive, not only through this $15 million bonus pool, but with a rate that was for some of these procedure codes, a fairly significant increase, ranging from 20 to 30%.
Thank you. Senator
Yes,
Clark,
sir.
do you have any questions? Or do we have any members online that might have questions? Hearing none. Barry, thank you very much. We appreciate it, and we can help you over here. Give us a shout.
Yes, sir. Again, I appreciate the opportunity to present to you all, and if there are any questions from any of the members, please don't hesitate to contact me directly.
Thank you, sir.
Thank you.
Next up, do we have Tom Wallace with Florida online? We do. Tom, are you with us?
Yes, I am with you guys. Just bear with me a second as I'm getting the presentation up here.
All right. We see the initial slide. And so for the audience, this is Tom Wallace. He's the Deputy Secretary for Medicaid in Florida. And Tom, you may proceed whenever you're ready.
Great. So you guys can see the slide now and myself, right?
Yes, sir, we can. We can't see you, but we got the slide.
Pardon me?
I said we cannot see you, but we have the slide.
Oh, I got my video on here, but maybe you'll see me when I get rid of the video, potentially.
Well, yeah, actually, I take it back and see you're compressed. So we get the slide takes up most of the screen.
Oh, okay. Okay, great. Well, great, and thank you for having me here today. I'm Tom Wallace. I am the Medicaid Director over the Florida Medicaid program. Little bit of a background about myself here. I have been at the agency that oversees the Medicaid program for 23 years, and most recently as a Medicaid Director, which I came into this position in June of 21, so about a year and a half at this point in time. So we'll proceed on here, and so first here, just a little high-level overview of what we're dealing with in Florida Medicaid. So we currently serve 5.5 million people on the Florida Medicaid program. This includes 54% of the children in Florida. 54% of all births in Florida are covered by Medicaid, and more than 60% of all the nursing home days in Florida are covered by Medicaid. Prior to March of 2020, our program was experiencing really the first decline, or overall really significant decline in quite some time that we saw in our enrollment. And so we had gotten down to 3.8 million recipients. But then since April of 2020, since the PHE began, the public health emergency began, our program has increased dramatically. We have seen an increase of 45% increase on our Medicaid enrollment, or roughly 1.7 million additional people to get to where we are today. The main way that Florida Medicaid provides services to our Medicaid enrollees are through managed care, through our health plans. So under a program that we call our statewide Medicaid managed care program, also known as SMMMC program. Now we do nearly have 1 million people in the Florida Medicaid program who receive a limited benefit package. These are like those individuals that may have private insurance or Medicare. And I will say that, of those people that have full Medicaid benefits, 95% of those people are required to enroll in our Medicaid managed care program. So in Florida, we went statewide with managed care in 2013 and 2014. But as you can see on this slide, we have been in managed care for quite some time before that. You can see that we started with a limited managed care program back in the 80s, and then really implemented our first mandatory managed care program with the implementation of what we call the Medicaid Reform Pilot Program in 2006. That was done under a federal waiver. It was called the 1115 waiver. And then from there, our Florida legislators directed us to implement a full statewide program. And that was completed in 2014. So we went through the implementation process in 2013 and finally completed in 2014. When we started the program, it was fully integrated. So we had a fully integrated program. So that means it included medical services or dental services. So that would be pharmacy, be included as well, hospital, long-term care services, etc. But then our legislature had directed us to pull out the dental services as a standalone program. So currently, though our current contracts began in 2019 for our current program, with dental being carved out as separate dental plans, and that currently runs through December of 2024. So right now, one of the big initiatives that we're working on here in Florida Medicaid is drafting the next procurement. So the next cycle, which is the next contract period. So we know the current one goes through December of 2024. We're working on drafting a procurement now that we will go forward with, that would begin in 2025. So I'll get into a little bit more on that later on in this presentation. So under our Florida Managed Care program, we have 3 program components. So we call them the Managed Medical Assistance Program, the MMA program, the Long-Term Care Program, or LTC program, and then the Dental program. The Managed Medical Assistance Program has approximately 4 million Medicaid recipients enrolled into. So of the 5.5 million that we have covered lives, about 4 million, a little over 4 million are in the MMA program, and this provides your basic health insurance benefits that you might expect which includes physician, preventative care, acute care, pharmacy services, your transportation services are included, therapies, specialty care, and then also your behavioral health type services. So all that's covered under our MMA program. Then we have our long-term care program, and this is a program that provides home and community-based services and facility-based long-term care services for certain people who meet the nursing home level of care criteria. So home and community-based services, and then long-term care. Long-term care being your nursing homes mostly there. That's what's on that side. And then finally, we have our dental program. As I mentioned, it's been carved out in the second round that we have here. But that provides just all your dental services to Florida Medicaid recipients. So dental is a little bit different, where it covers for everyone who's rolled into Medicaid. Anyone can get the dental services. Just to kind of look at the footprint that we have here in the state of Florida, we have multiple plan types and multiple plans that provide the managed care services here in Florida. So based on the structure of our statutory language that we have, that created the program. We currently operate in 11 separate regions. So they're distinct regions in the state, and you can see them. Here's the state of Florida and the different regions that are labeled here based on the geographic. So they're just kind of lumped together. And you can see that they're 1 through 11, with 11 being the largest one. That's our South Florida population, or have the most folks in it, down to 11. So also here, I'm laying out our various plans that we have and where they are distributed throughout the state. So what you can see, it might be a little small on your screen there, but if you have it printed out too, you can see that we have right now 11 separate companies, managed care plans that are providing services to our Medicaid enrollees, and 3 separate dental plans that serve all those members. And then we do have some specialty plans as well that provide specialty services like HIV/AIDS, serious mental illness. So people that have serious mental illness, it can be in a specialty plan, and some child welfare specialty plans. Our footprint in terms of the number of plans was a lot larger, but as you guys might have experienced too in Mississippi, with a lot of mergers and acquisitions, we have kind of condensed it down, and so right now it's at 11. Okay, so how did we get our plans to participate in our program? So statute in Florida will dictate, and it's very specific here, and it dictates that we must competitively procure the plans through what we call an invitation to negotiate. We also call that, this is ITN for short, but it's an invitation to negotiate. So the invitation to negotiate is a 2-part procurement process, essentially. The first part includes a set of evaluation criteria that's very specific, and it's either outlined in statute, or it's determined by the agency. And then we use a fixed scoring criteria, and we publish that, and that is what is used to evaluate the bids that are coming in through the ITN. The top scores of that evaluation process are then moved on to the next phase, which is called our negotiation phase, where the vendors are selected based on best value. We come up with a list of best value criteria, and then the vendors go through that negotiation process. We call them in, and then we select the best value plan to serve our folks. One thing that might be unique to Florida that other states may not exactly have is what we call the blackout period. So this essentially begins with the posting of the first procurement documents, and will run through the awarding of the contract. So during that time period, the procurement cannot be discussed with any plans or anything. The plans can come in and meet with us, but only to talk about current items, current structures, but nothing moving forward. So we have this blackout period, and we do see a limited number of meetings that occur during that period of time with our health plans, because they don't want to violate that process. So I want to talk to you a little bit here, when you look at this slide, a little bit about how we structure our Medicaid program in order to support Florida's managed care program, and ensure that we have a structured and disciplined compliance monitoring program that is in place. So when we went ahead and implemented the program, we reorganized the entire Medicaid structure. And when I talk about the program, this is the big program that started in 2013 and 2014. So we reorganized our Medicaid structure. And within that structure, we implement what we called a distributed compliance model. And so under this model, all functional areas within the Medicaid program have a role in compliance over various components of our managed care contract and our program. So for example, I've got 7 different bureaus that report to me. One of them is the Bureau of Medicaid Program Finance, and they're responsible for the oversight of plan financial reporting and medical loss ratios and something called the Achieved Savings Rebate, which I'll have a slide on and talk to you about that in a minute. But just wanted to kind of show you that each one of these functional bureaus that we have has a different part of compliance that they may need to look at and review. So within the implementation of our statewide program, we implemented a system that was really stringent on ensuring compliant actions were consistently taken. And what we do here, we use what we call liquidated damages, LDs. We got sanctions, and we also have corrective action plans that we can impose on our health plans. So we require that the health plans must pay the amount assessed through a LD or sanction. They must pay that, and whether they agree to it or not. So we send out a notice to them saying you need to pay this, and they have 30 days to pay it. And what happens is the plans do have a 21-day time frame where they can go ahead and basically challenge that if they like to. Take an appeal action basically is what it is, and they can appeal it, and it's appealed up through myself here, and as being the Medicaid director, and only the Medicaid director in Florida can reduce or rescind that compliance action, whatever it might be. I wanted to show you guys kind of how we look at these compliance actions. We do have a public-facing compliance reporting dashboard, and I know it's real tiny and small to see, but I just wanted to kind of show you what we have in place here and how we do this. So, one of the key elements of our approach to compliance here in Florida is transparency. So this is again, like I said, public-facing dashboard. We update it continuously. And this is just kind of an example of the type of things that are put out there. I will tell you, with having something that's public-facing like this, we do get media or newspapers that often look at this and will write articles based on what's posted out here. So that's one downside of it, potentially, because they might not exactly interpret the information how it really is. However, we want to get it out there so all the plans can see exactly what's being, the LDs, that's being assessed against them. So on the left-hand side here of the screen, these are just our, I won't go in detail, but just want to say, we got different categories that we look into on this, provider services being one of them at the bottom. This is where we kind of look at the network adequacy requirements. All our plans have to have strict network adequacy requirements, all in the contracts, time and distance standards, and if they don't meet those, then we do provide or assess damages against them. And on the right side, we just kind of show rolled up for the year or for any time period, because it's a dashboard. Anyone in the public can select it, the plan, how many actions have been taken against them, and the dollar amounts associated with them. So again, this is just something that we wanted to do, just to be very transparent out there on our compliance. And then I would like to say, a core component of any state's Medicaid managed care program are the rates. The rates that they pay the health plans. Florida uses a risk-based, risk-adjusted, capitated model for our medical long-term care and our dental rates. Our vendor, which I think is actually probably the same vendor that Mississippi uses to set their capitation rates, but we use, the vendor uses a variety of information from a variety of different sources, including demographic data they look at, utilization, cost trends, any type of program changes that the agency has done or delivery system changes, anything that the legislature has adjusted that the agency has to implement. So all these things, as well as other inputs that you can kind of see on the slide here, go into developing these actuarial sound rates. You know, an actuary sound rate, it's got to be a reasonable, appropriate, and attainable cost, for providing the required, care and services for administrating of the contract to take care of our Medicaid recipients. So these costs would include benefit costs, administrative expenses, administrative fees and taxes, and cost of capital. And in developing these rates, we use claim data. So we have historical claim data, and we look at the relative risks of the enrollees, and they assign what we call risk scores, and then aggregate that by the plan to see how each plan's enrollees compare back to the average, Medicaid recipient. And this then goes ahead and adjusts the capitation payments for expected expenditures based on the health status, and makes it like an equitable comparison among all of our health plans enrollees when that process is done. And so this minimizes the incentives for plans to selectively enroll healthier members when we go through that process. And again, we have a vendor that sets our capitation rates. And on the slide, kind of on the left-hand side, just get a little snippet so you can kind of see what it looks like, just real high level. We got rates that are done on what we call the rate cell basis. That's the individual groupings. So it's based on age, based on, different male, female, so sex there as well. And that's the MMA rates, and then below is going to be our long-term care rates. So it's same process in general, but you have as I explained earlier, we have a home and community-based services piece and a non-home community-based services, which is nursing homes. So those rates are kind of separated out and then come back together for one blended rate that we pay our health plans each month to take care of those members. And then I did mention I wanted to kind of get in details a little bit about our Achieve Savings Rebate with you guys. And this is something that it seems to be what Florida does. Maybe other states do something very similar, but I haven't really come across that. The Achieve Savings Rebate is essentially a profit-sharing mechanism that the agency has with, or the state has with, the health plans. So this is a unique mechanism to capture information about a plan's expenditures, to return excess plan revenues to the state, and to incentivize higher performance of our health plans. It's one key component to incent them to be even a better plan. And so we do this through this ASR, or Achieve Savings Rebate. So under this Achieve Savings Rebate, plans are able to retain a certain portion of their profit, but must return some portion to the state as well. So the program is structured so that the health plans pay into their ASRs. So they're the ones that are paying our audit firms. We hire an audit firm. The plans pay that audit firm essentially to produce these financial reports and audited financial reports to the agency. And you can see on this slide here kind of how it works on the far right bottom corner. But before that, I'll say that our capitation rates that we develop, and I know each state's a little bit different, but you go ahead and put in there profit and margin essentially, and profit being how much that we anticipate that the plans are making. So we go ahead and already build in some profit. And here in Florida, we build in a 2% profit already into the capitation rates. And then with this ASR structure, the first 5% of profit that the plans get to keep 100% of that first 5%. So anything from the 1 to 5%, plans automatically get to keep that profit. If the profit's between 6 and 10%, then that is shared with the state 50-50. Plans keep 50%, and then the state will get the other 50%. And then any profit that's over and beyond the 10% that the plan makes, so if a plan's doing very, very well for a year, then they have to return all that to the state. I will just point out real briefly, you do see that there is 100% in blue there for 6% under this quality benchmarks. So plans do have the opportunity to actually gain an additional 1% and keep 6% of the first 6% profit. However, since we've had this program since 2013-14, no plan has even done that. They have to meet very strict performance measures there in order to get that. And we haven't seen any plans really wanting to get that additional 1% quite yet. We're hopeful they will, but that might be in the future. I will say too that because of we're in this time we're in now, the last couple of years with COVID, where we can't disenroll anyone from our Medicaid rolls because of public health emergency. We've got a lot of people on our Medicaid rolls that are non-utilizers, are not utilizing services, and we, as a state, still have to pay that managed care plan, that capitation rate each month. So we're paying for a member that's not getting any services. So what we've seen for the last couple of years when we're looking at these achieved savings rebates is there's a lot of money that is being returned to the state. All that tells you is that the plans are making a lot of money at this point in time. All right, moving on to my last slide that I have here is just kind of looking into our future. And like I said, we're in the process of moving into our next round of and working on that procurement documents so we can get that out, that ITN out on the street here. So we have to reprocure. And so as we go through this, we see this as a cycle of an opportunity. This cycle of an opportunity to move the program forward in big steps. This is our chance here. So in advance of the reprocurement process, we typically post what we call a request for information. We send that out. It's a public seeking input mechanism. So we send out a request for information and the public responds to that. Mostly managed care plans, but we have a lot of providers and companies as well. So we did that and we put that out there, and in this cycle we got certain items that we're focusing on here, and a couple of them are on the screen. These are the main items. So we were looking to improve our birth outcomes for mothers and infants through and beyond the 12-month postpartum coverage period. So we want to increase that and give them the best care that they can. We want to utilize value-based purchasing designs to simultaneously increase quality and reduce costs. We know value-based purchasing is a big player here. That we do have in Florida, have a big provider group, a pediatric provider group. They're called Pediatric Associates. I do think they're in some other states. I'm not sure about Mississippi, but Pediatric Associates, they currently do utilize a value-based payment design model, and we're looking to, maybe potentially use that for other instances as well, other provider types. We're encouraging sustainable economic self-sufficiency among Medicaid recipients in the short and long term. So we're looking for that pathway to prosperity, so to speak. Maximize home and community-based placement and services through a proactive aging in place strategies. We're looking to align quality measures and outcomes with our Florida State Health Improvement Plan. So we have our public health agency. It's called the Florida Department of Health. They have a state improvement plan out there. So we're looking to align with that. We're also looking to improve the coordination of care for individuals that are enrolled in both Medicare and Medicaid programs, so like your dual eligible folks. And then lastly here, looking to improve mental health outcomes for children and adolescents there. So these are the things that we put in that RFI and got comments on from entities, and what we're looking to improve our program on as we move forward. So with that, Senator, and Chairman, I think that concludes everything I had to kind of update you on. Hopefully that got at the main points that you were hoping to see from me today.
Thank you, Tom. You did a very good job. I've got a few questions for you. Staying with this slide that we're on and taking a look at the postpartum care, am I to assume you've already extended your benefit out to 12 months?
Yes, and thank you for that question there. We have, and this was a I'll tell you, this was something that the Florida legislature had passed back in the 2021 session. He had, really, it was I say he because it was really the Speaker of the House's priority to extend that coverage, because Florida had been covering 60 days, basically 2 months, and he wanted to extend it for an additional 10. So it was passed in the Florida legislature. We got the appropriate appropriation, so the funding to cover it, and we just had to get the authority from federal CMS to move this program along here. And so we got that direction in the legislature, and then what the agency did was we moved forward by holding a 30-day public meeting, a comment period, because this has to be done through a waiver. Well, it doesn't have to be done through a waiver, but we elected to put this through in what we call 1115 waiver for CMS rather than the state plan amendment side. I know a lot of states have used that state plan amendment side, but we went down the waiver path because we had started this a while back. And so we requested that authority back in September 3rd of 2021. And then, so again, yes, it was September 3rd, 2021. The legislature passed it in the spring. We submitted all the documents to CMS in 2021, September 3rd. And then CMS finally came back and approved it for us on May 25th of 2022. So we're just now getting into this. But the good thing was when it was implemented or approved by CMS, the implementation date is retro back to July 1 of 21. I will say that since we're in the public health emergency and we have not had to, we can't disenroll anyone, that these mothers are essentially getting the services that they need now, but now it's official with approval of the postpartum coverage. So yes, it's a good thing, and we have full authority of that.
Thank you. How has your dental plan carve-out worked?
Sure. This is something that it was, like I said, it was originally put into the plans where the managed care plans would then see the care of the dental patients as well. So they had a patient came in, they could do their medical, they could do their dental at the same time, or they took care of that person. The legislature determined that they wanted to carve that out and have the agency contract with separate dental plans. But what we've seen here is, these dental plans that we now have a direct contract with, they were the same plans that our managed care plans were using, but as a subcontractor. But now we contract with them. So it was just pulled out, and we're using them separately. They now have we have separate quality metrics and quality measures that we gauge our dental plans on. And so we hold them accountable too. So everything I was talking about with these LDs and sanctions, the dental plans are held to those as well. I will say that this was an item that during the last session for us, which was in 2022 legislative session that concluded in March of 2022. That session, there was a bill being proposed originally that was trying to carve dental back in. And so it would have, if it went back in, everything we're dealing with now would have included it again back in, but that did not pass the legislature. The legislature had determined they'd rather keep it carved out. So that's where we are today.
And how many MCOs do you have in those dental plans?
We have three dental plans. And if you, I know it was hard to see, but back on this slide here, this is something you guys can look at later as well. On the far right-hand side, we'll show you the three dental plans that we have, and each one of them, they're statewide, so they got to be statewide dental plans. Each one are statewide, serving all regions in the state of Florida. So we have DentaQuest, Liberty, and MCNA Dental. And those are the three entities that we contract with currently. Now, when we're going through our procurement process, like I said here, on our managed care plans, we will have to re-procure the dental side too. So our footprint on the dental might change, but the timeline's identical, the same. So it would be, those contracts end December 31 of 2024, and with new plans would come in on the 25th. So obviously it could be the same plans, it could be different. We just obviously don't know yet.
Any consideration to carve out pharmacy or go with a single PBM?
No, there's not. There has really been no appetite for that. Pharmacy has been in from the very get-go. I mean, that is something that has been discussed here. PBMs have been an issue in Florida, but that's not been brought up too much avail here of carving pharmacy out. So it's going to probably be, it will be staying in here for the next cycle at least. So we got at least until 2030 where pharmacy will be carved in, and I don't foresee it being carved out.
And I think one of the things that's impressive about your operation is your MCO compliance. And I think earlier this year you, fined one of your MCOs, and then you also suspended enrollment from them. Can you talk to us about that?
Sure, and thank you for that question. Yes, you're exactly right. So it's our biggest MCO, Centene, but it's Centene, right? Centene, known nationally. They are referred to as Sunshine Health here in Florida. And you're right, we did. You're well aware that they merged with WellCare. And during that time frame, we looked at a few things that we needed to go ahead and take a compliance action against them on. And so we did so. And in that compliance action we did, and that's probably one of the bigger things that the plans want members. They want to have members in here. So one of the bigger things a state can do would be to put an enrollment freeze on so they can't get more people. I mean, Sunshine is still our largest plan, even with that enrollment freeze. However, they obviously would want to get members in and get more members into their plan. But they are currently still under that corrective action plan. However, we are working through things with them, and we're going through that process. They have been very, very receptive to all of our questions. They have been showing us all the data to show us how they've improved drastically on things. So we're reviewing everything right now, and we're looking forward to when we can kind of move forward with that and get them off that corrective action plan. So I do think that that's something that will be happening here. But we got great relationships with Sunshine.
When there is an incident that occurs, do you give them warning or corrective action period? And I know you've got an appeal process in here, but or do you just come down with a penalty?
We essentially just come down with the penalty. We don't give them a heads up for the most part that we're sending anything to them. We'll just come down with the penalty. They'll have to pay it, but they have that appeal time. And I'll say, a lot of times when they appeal, it comes through me and I review it and I make that determination. Do I withhold it? Do I reduce it? Or do I eliminate it? It just depends on what the sanction is, or the LD is, I should say, or sanction. They could appeal either one. But typically, it just comes down on that. I will say a lot of the plans, if it has to do with the quality side, if they're not meeting their quality metrics or whatnot, the plans know if they're not meeting what they need to meet. So it kind of depends there, but we're not giving them a heads up that say that, hey, you will be getting a letter for compliance action here.
And then could you give me a couple of ideas on your sanctions that you put in place?
Yeah, they can be both monetary or non-monetary. It kind of just depends here. But one example of a potential sanction would be we have certain. A sanction takes it to the next level. So an LOD we have laid out in the contract. We lay all this out in the contract exactly what they would be LODs for. And then what potentially they could be a sanction for here is something that's greater and above and beyond what a typical kind of, you're not meeting a network adequacy requirement, your time and distance standard. If you're not meeting that, that's like an LD, but something beyond that. So an example potentially could be is some sort of a security breach or whatnot. And we have certain timelines when the agency is supposed to be notified of these breaches. So if something like that happened where like a HIPAA violation or something, and when the agency wasn't notified in that certain time frame, and we felt like like the plan might have been trying to, you know, hide something from us or something like along those lines, we could always just put in a sanction. So that's kind of just a quick high-level example.
Thank you. Other members have any questions? Senator Blunt, Senator Blackman? All right.
Thank you, Mr. Chairman. As it relates to the question that the chairman asked about the postpartum care, have you all conducted any studies to show the benefits of postpartum for the 12 months and going beyond 12 months?
Mr. Chairman? Okay, well, thank you for that question there, Senator. We haven't yet, you know, like I said, it's just been approved here, you know, May of 2022, just approved. 12 months is probably going to be, that's the 12 month, that's the standard. 12-month postpartum period has been the standard. That's what federal CMS, the Centers for Medicare and Medicaid Services, has been approving for multiple states. It's a 12-month period, so it's given these mothers an additional 10 months to continue getting their care, opposed to the 60 days. So get an additional 10 months. But at this point, we haven't done any studies. At some point, we can get to where we are, but that would have to be after the public health emergency ends, when folks can start being disenrolled from our program, and we can kind of really look to see what the benefits of all this is.
Okay, my second question, and it may have already, I apologize. Your managed care entities, do you put a restriction on the amount of administrative costs they can charge?
Yes, and thank you for that question. We do. So when we set the capitation rates, when our vendor goes through that process, there is a whole component there that's administration. There's an administration component there that is looked at, and the vendor will do a ground-up, build-up approach on the admin side to look at what that potentially will be and what it needs to look like. So it is a function, and it's built into our capitation rates. So it is laid out separately.
Do you have an idea as to whether it's 5%, 10%, 15%?
Sure. I don't, so we just, our current capitation rates were effective 10/1 of 22, and I just can't, I don't have it in front of me right now, so I apologize for that. And this is something I definitely can follow up with you guys on and send you an exact number on this, because it's all public too. But it's roughly, I'll just say roughly in the 10% territory.
Okay. And my final question, is it, when your Medicaid recipients are involved in lawsuits and if should they recover, Medicaid recovers some portion of that money that it has been expended. Do you all, through your, do your managed care entities, do they keep those funds, or do they go back to your Medicaid fund?
Yeah, thank you for that question. We have, I'll say we have a whole unit here called our third-party liability unit, and we also have our fair hearings office under our general counsel's office. Every one of our Medicaid members has an opportunity to have a fair hearing if they wanted to appeal services or think they didn't get the services they need or whatnot, and they could file a lawsuit on that. I'm trying to, I don't really know if I have an exact answer, so if they, who gets that money back there. I don't believe that the managed care plans do. I mean, I think that's something outside from them, but I'm not 100% sure on that answer.
Okay, thank you, and thank you, Mr. Chairman.
Any other questions? Questions from any members online? Hearing none. Tom, thank you very much. Enjoyed the presentation.
Great. Thank you, senators and chairman. I appreciate the opportunity to share with you guys and the state of Mississippi what we're doing here in Florida. And feel free in the future, Mr. Chairman, to reach out, and I'll be happy to come back and talk about anything else with our Medicaid program. I appreciate it.
Thank you, sir. So that'll conclude this morning's session. We'll be back at 1 o'clock. We have Connecticut and Louisiana, which will be presenting. Louisiana is an MCO state, and then Connecticut is all fee-for-service. And incidentally, both of them are expansion states as well. And Senator Blackman, to your question about the postpartum, I think with this, the PHE and the extension, one, I don't know how many women know that they actually are eligible for that extended care period. But I think until this thing ends, I don't know that anybody's really looking at any outcomes. the hearing back to order, and I think we have, is it, Mr. Wilson, is it pronounced Guy?
It's Guy Woolston, Chairman. Thank you so much.
Guy Wilson?
You got it. Yep.
Okay, well, we have Guy Woolston here. He's the Director of Medicaid in the Division of Health Services in Connecticut. And we appreciate you taking the time to present to us today. And you have the floor.
Great. Thank you very much, Chairman and members. Thank you so much for the opportunity to speak with you. It's my understanding we have a 45-minute slot, and it was my plan to talk for roughly 30, 35 of those minutes and then open it up for questions. Logistically, is that what would be most helpful to you, Chairman?
Yes, sir, that's correct.
Great. Okay, terrific. I'll share my screen in a moment. I'll talk about Connecticut. Just a tiny bit on me. So as the Chairman mentioned, I'm Guy Woolston. I am the Medicaid Director in Connecticut, and it's a real honor to speak with you about our program. In many ways, Mississippi and Connecticut are very different. We're different geographically, we're different politically, but in many ways, we're actually very similar. We have roughly similar population size. Our Medicaid programs are roughly the same size, about 1 million members each, and I think it's really important to talk through different models, and I'm really happy to have the opportunity to address you all. I'm going to go ahead and share my screen, and let me just get this going. Terrific. So what I'm going to do, I'm going to start with a brief overview of Connecticut's model and the history of how our Medicaid program came to be. I'll then talk a little bit about comparing our model, the managed fee-for-service model, to managed care in the context of Medicaid. I'll then talk about how's Connecticut doing, share an additional thought, conclude, and then open it up for questions for you all. So I'll start with just an overview of Connecticut and its model. So just a little bit about us. We have 3.5 million people in Connecticut. We have roughly 1 million members on our Medicaid program. And like in many states, including Mississippi, we disproportionately cover children, people in nursing homes, people with individuals, and Medicare beneficiaries. I think what is unusual about Connecticut is that we are one of only 2 states to have no comprehensive managed care plans in Medicaid. Just a little bit on my background, I'm obviously my role here in Connecticut, but at my heart, I'm a private sector person. So I've been in state service less than a year, and previously I came from the health insurance industry, working as an executive at CVS Aetna. And so it's been really interesting seeing both sides, both the private sector and on the state side. So as I mentioned, Connecticut is unusual in that we have no managed care in our Medicaid program. A handful of other states, including Alabama, North Carolina, and Oklahoma, have very little managed care, but Connecticut and Alaska are the only 2 that have none. And it's a real pleasure to address you all about our model, what we do, what I think some of the pros and cons are. Just a little bit of detail on the model itself. So, and the text in blue is pretty similar across states. The text in red is what is different about Connecticut. So we have a single state Medicaid agency. That's where I work. We partner with sister state agencies for specific roles, for example, on behavioral health or addiction. We work closely with our Department of Public Health, as I'm sure does your Medicaid program. What makes Connecticut different is that we don't have managed care, so we are at financial risk internally here in Connecticut. Instead, we oversee contracts with 3 what we call administrative services organizations, or ASOs. And those organizations are for medical, behavioral health, and dental. And then we have a non-emergency medical transportation broker. So I want to spend a little bit more talking about what is an administrative services only organization, how does it work, what are some of the pros and some of the cons. So to start, I just want to contrast 3 different models. On the left here, you're going to have traditional fee for service. And an example of that would be traditional Medicare, Medicare Part A, Medicare Part B. In a traditional fee-for-service model, the payer, like the federal Medicare program, sets the rates and determines benefits for the program, and there's generally little care management or utilization management. To some extent, the payer is setting the rates and then kind of letting healthcare play out. Connecticut here in the middle has what we call a managed fee-for-service model. Connecticut's Medicaid is this way. Most large employers, self-insured employers, have a very similar structure, like Walmart and Amazon, where the payer, whether it be Connecticut Medicaid or Amazon or Walmart, will set the rates and determine the benefits, what's covered, what isn't. And then the payer, Amazon, Walmart, Medicaid, Connecticut Medicaid, will hire an administrative services only organization who kind of runs the nuts and bolts of the program. They conduct utilization management, the care management, they often do customer service, things like that. So, a Walmart or a Amazon might hire a company like Aetna or Blue Cross as an administrative services only organization. And then on the right, you have, capitated managed care organizations. An example here would be Medicaid managed care, something like Centene or Molina. And obviously, within each of these three buckets, there's variation, but at its core, in a capitated managed care environment, the payer sets the broad regulatory framework, and then pays a capitation payment to managed care plans. And then the managed care plans set provider rates and network. They do utilization management and care management and set other policies. So on that spectrum, Connecticut's right in the middle on that managed fee-for-service model, much like almost all big employers, self-insured ones. So let me dive just a little bit more deeply into comparing that self-insured model that Connecticut and big employers have versus a capitated managed care approach. So in terms of like the payments themselves, on the self-insured model, Connecticut's model, we don't make payments to managed care plans. Instead, the state is at financial risk. If medical utilization went down during the height of the pandemic, that was savings for the state. If utilization is higher than expected, that's cost for the state. In contrast, in a capitated managed care environment, typically the Medicaid agency will pay a fixed monthly premium to a managed care organization. In terms of the risk, under our model, Connecticut assumes the financial risk, much like Walmart or Amazon does for its employees. Under the capitated managed care model, the Medicaid managed care organization usually assumes some or most of the financial risk, although through risk corridors, reinsurance, lobbying, some of the risk might be transferred back to the state. In terms of the plan design, Connecticut Medicaid controls and has standardized coverage, utilization management, provider payments, all across the state for our 1 million members. Typically in a capitated managed care environment, those decisions are delegated to the managed care organization. So each MCO develops its own, for example, provider network or provider rates. And then in terms of the data, we have a fully integrated statewide claims database because we're the single payer. In many capitated managed care environments, each managed care organization is collecting more limited encounter data and then sending that back to the state. So hopefully that makes it a little bit clearer on what we do here in Connecticut and how that differs from a more traditional capitated managed care environment. Just a quick history. Just sometimes it's useful to think about how a state got to where it was. So like I think every Medicaid program, we began as a fee-for-service program. In 1994, we began a transition to managed care. And then between 1995 and 2010, we used some form of managed care in the Medicaid program. It varied year by year, but generally low-income children and their families received their services through managed care organizations, while, for example, the elderly or people with disabilities continued to receive their care from fee-for-service. Starting in 2010, we transitioned back. So we got rid of managed care and moved it back to our ASO model. And we've had that for the last decade since 2012. As I mentioned, we determine what services are covered, the rates that we pay, utilization management and care management. We contract with those ASOs. And then we do directly administer parts of the program itself, like the long-term services and supports.
Guy, could I ask you why you guys transitioned back?
Yeah, it's a good question. And I was not in state service at the time, so some of this is a little bit of the lore from 12 years ago. It was several-fold. Some of our advocates were concerned that putting Medicaid, having at-risk Medicaid managed care providers might create incentives for the managed care plans to under-provide service for some members. So that's part of it. Part of it, as I understand, was the belief, and I'll get to this in a moment, that the administrative costs of running the program might be substantially lower if we did it in-house ourselves. And briefly, I'll have a slide on this in just a second, but briefly, for a medium-sized state like ours, like Mississippi or Connecticut, if you end up having 3 or 4 managed care plans, there's a certain degree of, there's fixed costs of running a health plan that I know very well from my private sector side, and it kind of doesn't matter if you have 100,000 or 1 million members on the plan. And by having one that's run by, by the state versus having 4, you can save money, and you can see that our administrative costs are substantially lower than most other states. Is my understanding that those were the 2 main drivers. Great, and please keep questions coming. I don't mean to have this be a lecture by any stretch. I wanted to touch base on 4 claims that you hear related to fee-for-service versus managed care. And I want to just touch on the evidence behind them. Claim number 1 is that Medicaid managed care can reduce state spending. Claim number 2 is part of the ways that which they do it is by having a smart provider network, contracting with high-value providers who help reduce spending by lowering prices. Claim number 3 is that Medicaid managed care kind of take a lot of the financial risk away from the state. And claim number 4 is that managed care can help improve health outcomes. I want to spend a minute just to share at least my reading of these are, by the way, these are hard, tough, thoughtful, claims that people make. And I want to spend just a moment talking about what I see as the evidence in favor or not of those claims, recognizing that different thoughtful people could come to different conclusions, because I don't think with any of these we have definitive answers. And this relates actually, Chairman, to your question about why Connecticut transitioned way back then. So on the first question, people often claim that Medicaid managed care can reduce state spending. I think there are good reasons to think that might be true. I do think there are good reasons to think that managed care might increase state spending. So I want to touch on those and then talk about why they might decrease. One is that when you bring in managed care, you might split, a 1 million member Medicaid program into 4 different pieces, 4 different managed care plans. And in general, we know that having a fragmented payer market, having 4 companies rather than 1 organization, can reduce the market power that the payer has when they're negotiating with providers. And I don't know how it is in Mississippi. In Connecticut, our hospital system is highly consolidated. And I think there's pretty good evidence that when the provider systems are very consolidated, concentrated, having a payer that also has market power can help negotiate better rates. And if you fragment it, the rates can be higher. A second reason why managed care might actually increase state spending is the administrative costs that I mentioned. So having 4 organizations versus just 1, if there are fixed costs of running the program, you end up paying for those costs 4 times. There are also, there are activities like advertising that you don't need to have in a managed fee-for-service environment, but you typically do in a managed care environment. Third, managed care organizations do make profits, and they have markups, as well they should, right? We live in a capitalist society, and I'm not saying that's a bad thing, but that does, those are extra dollars flowing from the state to someone. And then finally, patients often can switch between different managed care plans, and they do. In fact, one of the promises of managed care is that by giving members choice, it will help create competition, which I think is very real. But some of that choice can be bad because if a payer knows that their members may leave and go to one of their competitors, that kind of dulls the payer's incentives to invest in preventative care that can reduce costs in the medium run. On the other hand, there are good reasons, I think, to think that managed care organizations might decrease state spending. One is that managed care organizations have a really strong financial incentives to keep their members healthy. And they have more flexibility to cover services that might reduce costs, like related to social determinants of health. They might be able to be tougher negotiating with providers because they don't face the same political pressures that I at the state face. And they might just be better. The competition between plans might inspire them to operate more efficiently than we might in Connecticut without that competition. So I bring up the theory just to say I think there are good reasons on both sides to think that managed care might reduce or might increase state spending. In terms of the evidence, it's hard to know. It's not like we flip a coin and have half the states go managed care and half the states do fee-for-service and compare what happens. I want to share with you what I think is the best evidence on this topic. I want to be clear, it's not definitive, but I do think it's worth having it. And this is linking to a paper that uses national data, and it follows counties over time, where a state like California or Texas or others transition from fee-for-service to managed care, in some cases back, and would often do that at the county level. And so this paper, follows counties that transition from fee-for-service to managed care or back, before and after that transition, versus other similar counties that didn't, and just looked at, okay, did the total amount of money that the state is spending on the Medicaid program in those counties that transitioned versus didn't, how did that impact that kind of natural experiment, if you will? And this study finds it's a wash empirically. That they found no savings, but also no increases in costs. In part because state fee-for-service rates are often really low. In the cases where the fee-for-service rates were high, they did find savings. In the case where the state fee-for-service rates were very low, they found modest increases in state spending, but kind of on average, it was a bit of a wash. Claim number two that some folks make about managed care organizations is that part of the way that they add value is through their provider network, by deciding which providers are in or out of network whom we contract with. And in particular, one of the good stories, the exciting stories about managed care is that by being able to be selective about their network, they might be able to negotiate harder with providers and have lower rates. The story goes something like this. If I'm running a managed care organization and there are 3 providers in a given town, and I know I only need to sign up 2 of them, I can set a lower rate such that only 2 of the 3 sign up, and that can be good. I can lower total spending by decreasing the prices that we pay. And if you think healthcare spending is prices times quantity, reducing the price might be good. To try to put a little bit of evidence on this, there's a recent paper, and I realize actually I didn't include a link to it, so I'll make sure to follow up with the link offline. There's a recent paper that looks at people who are randomly assigned. In this context, there are multiple managed care organizations, and if a member did not choose, Plan A versus Plan B, they literally get randomly assigned to them. Some of the managed care organizations had very narrow provider networks, some had broad ones. So this design kind of allows you to kind of randomly see what happens when a member gets assigned to a narrow network versus a broad network. And that allows you to kind of compare the outcomes. In this context, at least, they find that having that narrow network does indeed lower spending. The effect, though, is driven primarily by quantities, not by prices. So if you have fewer providers in your network, it can make it more challenging for some people to get care. And so that's what I mean by quantities. And they found that when you move from a broad to a narrow network, utilization goes down both for low value care, which is great, that's what we want to see. Things like scans that aren't needed or drugs that are prescribed that aren't matter. So that's good. But also high value care like preventative services or getting on drugs like statins also went down. And this graph kind of just shows you that event study tracking high value care here on the left and low value care here on the right. And you can see when someone is assigned to a broad network, the utilization goes up on both prices and quantities. So that was claim number 2. So I think on this one, I think the evidence is pretty mixed, and at least I think the best evidence suggests that narrow networks can help save money, but they do so at a cost for reducing that high value care. The third claim that folks often make about managed care is that they help take financial risk away from the state and put it on private organizations, which can be really beneficial. If the state needs certainty over its budget, for example, that can be really beneficial. And I think this one is true. I think this is a real advantage of the managed care model. I will point out, though, that often this financial risk, this transfer, is incomplete in the sense that, and I don't know the details of Mississippi's program. I don't pretend to be an expert at all. I know in other states, there are risk corridors or carve-outs. During COVID, for example, there were kind of special accommodations made for managed care organizations. More generally, the practice of setting capitation rates based on past spending, all of those things kind of mitigate. I still think it's the case that managed care does take financial risk away from the state, but it may not be as complete as you might think at first blush due to all of these kind of other arrangements that complicate the picture to some extent. And then lastly, and then by the way, after I get through these 4 claims, I'm going to come back to Connecticut and how things work here. I just wanted to walk through these. The last claim that people make often about managed care is that it can improve health outcomes. Answering this question is really hard, in part because, as you all know, it's hard to know like what is good health. We don't always see that super well in our data. I did want to share with you evidence from one context in which I think we do measure health pretty well, and a context in which the Medicaid program, it's really important to the Medicaid program, and that's in the space of maternity care. So these 2 papers try to answer the question, at least in the context of maternity care, does the transition from fee-for-service to managed care or back, does that tend to improve or harm health outcomes like getting prenatal care or low birth weight or short gestation or neonatal death? And to try to separate correlation from causation, both studies, they differ a little bit in their approaches, but I do think they do something that's pretty clever. They look at California and Texas, where, as I mentioned, the transition to managed care was staggered at a county level. So, in some years, some counties transitioned, and a couple years later, other counties transitioned. So that's a nice kind of natural experiment. And at least in the California case, they do something even more clever. They look at the same woman, the same pregnant woman, over time. If the first kid was under fee-for-service and their younger sibling 3 years later might be under managed care, they're looking to see how health outcomes change during and shortly after the transition to managed care. In both of these contexts, both in the California and in the Texas context, the transition to managed care led to some potentially concerning outcomes. So in the context of California, the transition to managed care caused a large decrease in the use of prenatal care in the first trimester, which research suggests is really important for the health of the fetus. If you're thinking kind of a cradle to grave, kind of pro-life, it's starting with the prenatal care, and led to an increase in the incidence of low birth rate, short gestation, and neonatal death. And in the context of Texas, using a similar approach, researchers sort of found that the transition to managed care tend to widen disparities between pregnant women who were low or high cost on average. In that context, that meant Black mortality, but in other contexts that might mean something different. Okay, so enough on the seminar, the research seminar. I want to just come back to Connecticut's model, what we're doing, how's it going, and then obviously pause for questions. And I should start this section by saying comparing one Medicaid program to another is really complicated. Our populations differ, the underlying burden of health differs, our benefits differ. So I find it very challenging to say, program X is better than program Y, and I certainly don't mean to be saying that Connecticut has it all figured out or anything like that. What I can say is that on the quality score, every year CMS has a Medicaid and SHIP quality scorecard, and we perform very well. Obviously, we're not perfect, but we perform very well on most of the health measures, well above the national median in our peer states for most of the quality measures. And then on the cost side, again, I think it's very complicated to do cross-state comparisons because some programs are more generous than others. The provider networks are differ. But we have had very stable and very low growth in our spending. I excluded the COVID years, just spending went wild and went up and down a little bit in many states, including Connecticut, but at least in the pre-COVID era, our spending went up by only 1.35% on average for the 5 years with 2015 to 2020. Our administrative costs are quite low. They're only 3%. Many managed care organizations have much higher managed care, much higher administrative costs, reflecting some of the dynamics that we described. And this last thing, although again, I emphasize it's hard to make comparisons, I will say that the percent of our state budget that goes to Medicaid compares very favorably to national averages, peer states, things like that. I wanted to just close with two more thoughts. I hope I talked through some of what I see as the advantages and disadvantages of the two models. I just want to share like a little bit of a potpourri of things that you wouldn't normally think of, but I think are important. So I think one advantage of the Connecticut's model, that managed fee-for-service model, is it makes things simpler. Our data is unified and 100% comparable all across our state. Our formulary and the member experience is unified. And I think that can help for a medium-sized state like Mississippi or Connecticut. It just makes things simpler to have one experience for our members, one formulary, one member experience. It also gives the state, for better or worse, more control, I think for better often, but more control over strategic levers. Things like provider rate setting or prior authorization. If the legislature and the governor decides tackling a particular issue is a real priority for the state and their voters, it's much easier to affect that change quickly and easily because the program is run internally by our state. In a managed care model, the policy levers are a little bit more indirect. I do think there's some challenges, and I hope I've been upfront about a bunch of challenges all throughout. I'll end with a couple of challenges. One is we have less administrative flexibility from CMS. A good example of this is in the social determinants of health space. Imagine you have a Medicaid member who is really needy. She's using $100,000 of medical care per year, and she's going to the emergency room for unnecessary things. And the thing that she really needs, the reason that she's going to the emergency room is she didn't have good heat or good air conditioning in her house. In the managed care environment, the managed care organizations can pay for an air conditioner or heater for the house, and they have financial incentives to do so because that may reduce those really expensive emergency room bills. And CMS, there's a lot more flexibility to do that. As a managed fee-for-service state, we have much less flexibility to do that from CMS, and kind of everything that we want to cover outside of the traditional what's included in Medicaid, we need to apply specifically to CMS for a waiver to do it, and it just makes it much more administratively complicated. A second challenge, and I think this is not particular to Medicaid, this is always like should the state provide it or should we outsource? There's some flexibility which coming from outsourcing that you don't get when the state does a function itself. Great. So my last slide, and then I'd love to open it up for questions or comments. I just wanted to go back to the slide that we looked at before, but just for me, I find this really helpful to keep straight, what is Connecticut doing? How does it compare to other models? So again, we have the traditional fee for service like Medicare. We have the capitated managed care, like the Centenes or Molinos of the world. Here, Connecticut has, the model very much in the middle, much like almost every big employer in the country. We're self-insured, and I think there are pros and cons of all of the models. But I hope that some of the information I provided today can be helpful for you all as you're thinking through where you want to take the Mississippi Medicaid program. So let me pause there. And I just want to say again, thank you. I think probably all of us who work in the space care a lot about learning from other states and sharing, and I really appreciate the invitation to speak in front of you today.
Thank you, Guy. You're an expansion state, aren't you?
We did expand, yes. Yeah.
How many more enrollees did you achieve when you went to that expansion?
It's a good question. I have that number. I have that number not quite handy, so let me see if I can pull it while pull it up, and hopefully by the end of the presentation, I can get that for you. I will say just I think the policy question of whether to expand or not expand Medicaid, it relates to the managed care versus not decision, but I do think of them as being separate. Just for example, like Connecticut had managed care and then fee for service, then managed care, then fee for service again before expansion, and we have the managed fee for service now as well. Oh, Chairman, I think I found that number. Wait, give me just 1 second. Shoot. All right, let me keep looking. Sorry about that. I thought I had it.
That's all right. During this, the PHE, we've experienced, an increase in enrollment, but we have not had that same increase in expenditures. Are you guys experiencing, and we've talked to a couple of other states today, and they've experienced the same. What's your experience been during the PHE?
Yes, great question. Very similar, and I think this is true nationally, and I think there's a very good reason for it. Sorry about that. Obviously the expanded Medicaid rolls as part of the public health emergency hits across the program, but here in Connecticut, and I suspect in every state, if you look at where the increase in enrollment has been, it has been disproportionately in the parts of the program that are lower cost on average. These are moms and kids, for example, whose income might vary as the mom gets a new job and is pulling herself out of poverty, which is a great thing. So that's the place where we've seen the biggest expansion in our enrollment since the public health emergency. Those are also the members that on average cost the least relative, for example, our members who have disabilities, who qualify for Medicaid from their disability. So our average costs per member per month have fallen. Obviously the spending has gone up because we have more people, but the average cost per member has gone down substantially. And I expect when the PHE unwinds, our PMPMs will increase as well. And Chairman, that's part of the reason when I was quoting what I was saying, our costs have been very stable, and I kind of ended it in 2020. I didn't want to give Connecticut credit for the falling and PMPMs that we and many states have, or the lack of increase in PMPMs that many states have seen. And I did find that number. We have approximately 300,000 members in our ACA expansion population. So of the million, we have roughly 300,000 members in that market.
Was that more or less than what you expected?
It's a great question. I wasn't in state service in 2014 when we did expand, so I'm not sure.
All right. How do you set your PMPM?
Great. So so we have no managed care. We don't. Put simply, what we do is we set rates for every provider. You know, much like the federal Medicare program or like Walmart or Amazon. We have a physician fee schedule. We have a hospital fee schedule. We set nursing home rates. And then every month, our members consume healthcare, and we pay based on the fee schedule, the way that we've set the rates, and that's what our costs are.
Right.
So we don't really have the same concept. I mean, obviously, the PMPM is we can divide the total spending by the number of members, but we don't set the PMPM. We set the policies and the prices that we pay, and then the PMPMs flow from that.
And when you set your rates, what base do you use? Do you use Medicare or do you use commercial rates?
It's such a good question, and like many states that have at least a portion of their program as fee for service, Chairman, the answer is it's complicated, and our rates at the highest level are set by our legislature, and we always look to Medicare and commercial. But the legislature, has spending priorities, and in some years, they decide, for example, not to update the rates that we pay a certain group of providers, and so it may be frozen over time, or some years they choose to increase it. So I guess I would say it's a policy decision that the legislature makes, and we look to Medicare, we look to commercial, but it's done on a little bit more of a case-by-case basis.
And can you share with us what your budget is, maybe just your, coming from the state support side?
Our total budget is approximately $8 billion. I should, but I don't want to give you an incorrect number for the state share, so I'm going to hold on that one. But it's less than half, and I should know that number. I should have that number tattooed to my forehead. I don't have that for you, Chairman, though.
And then lastly, on your claim number 4 slide.
Yes.
That California case that you talked about, I mean, the results are just the direct opposite of what you would expect from a managed care provider. Do you have any comments on how they could basically be worse than what you would desire?
I do. I do have some comments. But I want to be clear, like with many complicated things in life, I'm certainly not saying that the 2 studies that I had here are the definitive word or the only thing. I wanted to share them because I think they are very well done studies that have gotten a lot of attention. But there certainly are there's evidence on both sides. But on the theory of the case, yeah, I mean the concerns that some people have with managed care. And I want to be clear, I'm not speaking in my role as Medicaid director. I'm communicating what I think some people think. The concern that some people have with managed care organizations is you're going to give an organization, often a for-profit organization, a fixed amount of money for managing and coordinating the care of their members. And then they're at financial risk, right? So you transfer $4,000 over the course of a pregnancy, and then if the member ends up consuming more than $4,000, the managed care organization loses money, and if they consume less than $4,000, the managed care makes profit. And that's the promise. That's the whole idea of efficiency, competition, things like that. Some people are concerned that when you do that, when you put a managed care plan at financial risk, they might have financial incentives to provide less care, because if they provide less care, spending might be lower and their profits might be higher. So I think that the concerns that some people have with managed care is that kind of under provision or stinting that comes from their being at financial risk. How that might manifest itself in the context of pregnancy would be things like not enrolling as many providers who could provide maternity care, or not having as active care management to encourage pregnant women to get the managed care, the prenatal care, things like that. I want to be super clear in the California case. You know, the researchers are just looking at the outcomes themselves. They don't have the data on the number of phone calls that were made or the provider networks, things like that. But I think the proposed mechanism is through the financial incentives that managed care organizations have.
I would think that with the medical loss ratio, the managed care folks would probably be more incentivized to make sure that care is provided. Because if not, they're just going to give up that money.
Yeah, I think it depends on if and I know every state does this differently, depends on if the medical loss ratio regulation is binding. You know, if it's not, if there's a 85 or 90% floor, and if a plan is at 91%, their financial for every dollar of decreased medical utilization, that's a dollar more of profit to the managed care. I want to be super clear. I'm not suggesting that that's all nefarious or bad. I think many of the good incentives that managed care organizations have, can come from their desire to try to keep people healthy and decrease medical costs. But that's the theory of the case for under provision or stinting.
All right, thank you. Do we have any members online that have questions? Anybody online? All right. Guy, thank you very much. We appreciate your presentation. Thank you for taking the time to join us.
Yeah, thanks for the invitation, and I wish you the best of luck in your policy reform agenda, Chairman.
Thank you, sir. Last but not least, today we have Louisiana, who's going to present Tara LeBlanc, who's the Medicaid Executive Director for Louisiana. Is Tara with us?
Yes, sir, I am. And if you will hold on, good afternoon, everyone. If you'll hold on, I will let me get my screen to share the PowerPoint, or would you like me just to talk through the PowerPoint without? Do you all have the copy of the PowerPoint?
We have copies, so that's up to you.
Okay, well, I'll just talk through it. It's much easier. Again, it's a pleasure to meet you this afternoon. My name is Tara LeBlanc. I am the Medicaid Executive Director for Louisiana. I do have two other members on the line just to join in case you guys ask some hard questions to me. I have my subject matter expert on is Ms. Kalinda Parker, which is our Medicaid Deputy Director over Program Operations and Compliance, which is the majority of the managed care operations, and Tangela Womack, which is my special projects officer that helps gather and has a lot of information as well. So I will start off today just by giving a little background about Louisiana and when and where we moved to managed care. We have over 2 million residents on Medicaid as of the end of October. I do want to point out that beginning the public health emergency, we had about 1.6 million, and now we just went over the 2 million mark at the end of October. So the majority of our increase has been due to the COVID maintenance of effort. We have over 750,000 adults who are enrolled through the Medicaid expansion, and over 90% of our Medicaid population is enrolled through one of our managed care organizations. Louisiana, we currently have 5 managed care organizations that deal with the fiscal health of individuals. However, it's worthy noting that January 1, we'll have our 6th plan joining us, and we have one behavioral health prepaid plan for we call it the coordinated system of care, which is a small population of children less than 1,800 with behavioral issues. So it's really a specialized behavioral health. Some of our juvenile justice type children are included in adolescents. We have 2 dental prepaid ambulatory health plans. And then we also have the Medicaid fee-for-service. No, I'm sorry, the Medicaid fee-for-service population has specialized behavioral health covered through our managed care organizations. The MCOs pay for Medicaid benefits and services included in Louisiana state plan, our state statutes, administrative rules, Medicaid policies, and our procedure manuals. MCOs also provide specified value added benefits and services. Some history about the transition to managed care. On February 1st, 2012, Medicaid transitioned nearly 900,000 Medicaid members from the state's 45-year-old fee-for-service program. The rollout occurred in phases and was completed by June 1st of 2012. And the goal of the transition at that time was improving access to care, improving care coordination, increasing emphasis on disease prevention, early diagnosis and management of chronic conditions, improving health outcomes and quality of care, and ensuring a more financially stable Medicaid program. And in 2014, Medicaid issued a request for proposal for its 2nd generation of full risk Medicaid managed care contracts. This result was a contract with 5 MCOs. Previously, we had 3. This RFP was an initial 3-year contract with the option to extend up to 24 months. And our Louisiana legislature did grant the 24-month extension from February of 2018 that expired to December of 2019. And in 2015, we integrated specialized behavioral health services into the managed care program. 2017, Medicaid began drafting its 3rd generation of the RFP. In 2019, that RFP was issued. What the next slide goes into a lot of our steps, but I'll let you know that our 2019 RFP, we ran into some protest. And basically at the end of the day, last year, our current 5 plans, we just kept doing emergency 1-year contracts. And then last year we issued an RFP that was supposed to go live July 1st. However, we ran into some protest again. That RFP is going live January 1 of 2023, and we actually will have the 6th plan as a new entrant joining us. And we refer to our MCOs as Healthy Louisiana plans, just for context. The next slide is I do want to spend a little bit about some of the lessons learned that we have had in Louisiana with our managed care. Our goal of our new contract starting January 1st was to focus on some areas where we either believed we had gaps in services and or where our language in our contract was not quite stringent enough or explicit enough. So we added a lot of details in these areas. I will say that one of our biggest lessons learned in managed care is to make sure that our contract actually is explicit in our expectations, and our liquidated damages and penalties are explicit based on if the plans does not follow what our expectations are. So we feel like our new contract January 1st, we've corrected a lot of those issues. And one of our big changes that will happen with our new contract is a single pharmacy benefits manager and a single transportation manager. One of the things that we realized is that for the pharmacy, the PBM portion, with having 5 plans, they all had their own enrollment broker, their own PBM as well. There was a lot of administrative burden on the department with Medicaid as well as the providers, because it's 5 plans you have to deal with. Even though the state has one single formulary, it's still a lot of administrative issues that arise just having 5 different versions. And then we would have the 6th one coming in as well. So that would have been an additional administrative burden. Also, the same concept with the single transportation broker. One of the other important points I would bring out that we believe a single transportation broker will help us do is reduce our no-shows on our non-emergency medical transportation. The philosophy behind that is that we currently have 5 enrollment brokers for the transportation, and if I own a transportation company and I've signed up and become a provider with all 5 plans, each plan doesn't know when they're scheduling with that particular provider. So that provider may actually have 5 at one time, but only have 2 cars, and they may only select the 2 highest paid or most profitable for them. So we believe that with one transportation broker, we will eliminate that, because it's only that broker will know each company's how many vehicles and their availability to be able to transport those rides. We also, our second lesson learned, we're also focusing on our child and maternal health outcome improvements. Louisiana has ranked very to the bottom of the maternal health, so we're trying to improve those health outcomes with that improvement. We're also doing our delivery system reform, our value-based payment. We are reforming that and ensuring that we are making payments for valued services, and that there are no gaps in services for our members. There's a big focus as every state is moving towards the health equity. So we do have a big focus and a lot of requirements for our managed care entities around health equity. Disaster planning and recovery. This was focused more on lessons learned over the last several hurricanes, and around the last issue that we had with Hurricane Ida with the nursing home. We had a nursing home issue that individuals moved into an unsuitable location. So we have addressed some of that in our disaster planning and recovery. We also, behavioral health integration, we are continuously trying to improve our services and the quality of care for our Medicaid population around behavioral health. You know, every state nationally is the opioid crisis, the behavioral health, mental health crisis. So we did include quite a bit in that. We also have a Department of Justice agreement. It's around serious mental illness individuals that has been placed in a nursing home. That agreement has milestones, and at each milestone, we are to provide services in Louisiana. So our new contracts replicate the new services that will provide, such as mobile crisis solutions for adults and children. The next is we have strengthened our fraud, waste, and abuse initiative to ensure not only are we monitoring the MCOs, but are the MCOs monitoring the providers. And then we have a lot more in the increased MCO accountability area. Our Healthy Louisiana Plan expectations, we guided through a triple aim process. What we tried to do is improve our delivery system by improving the health population, enhancing the experience of the care for individuals, and effectively managing cost of care. And we also, our objectives with our managed care, just to provide some details of what we expect and what's in our contracts: advance evidence-based practices, high-value care, service of excellence. We support innovation in a culture of continuous quality improvement in Louisiana. We also try to ensure enrollees have access to care, including through innovative means such as medical homes and telehealth. We also improve each member's health and decrease fragmentation and increase integration across providers and care settings, particularly for members with a behavioral health need. Other expectations is use of a population health approach supported by health information technology to advance the health equity and address social determinants of health, reduce complexity and administrative burden for all providers and enrollees, and align financial incentives and building shared capacity to improve healthcare quality through data and collaboration, and minimize wasteful spending, unnecessary utilization, and fraud. I also wanted to point out some of our performance measures that we have the MCOs report annually on patient outcome performance. And we have some payments tied to this, which is the healthcare effectiveness data and information set, the HEDIS measures, CMS adult and children core sets, and the Agency for Healthcare Research and Quality, the prevention quality indicators, the consumer assessment of healthcare providers and systems, and then we also have state specified quality measures. And again, that may change in our contracts, but the focus is some of the items I've mentioned, such as the health equity and behavioral health service array. We also have a managed care incentive payment program called MCIP. And we know to increase the quality of care is incentivizing our managed care organizations through various ways, and this is one of the ways that we do it. We implemented this program in 2019, and the MCIP program, we do provide incentive payments to the MCOs for achieving quality reforms that increases health access to health care, improve the quality of care, and or enhance the health of MCO members. Our current quality reform, the details of it is we're focusing increasing members' access to primary care health, improving health outcomes for pregnant women, newborns, and enrollees with chronic conditions, and reducing inefficiencies and costs by reducing unnecessary utilization, promoting evidence-based practices, and reducing low-value care. What I did not also put in the PowerPoint, I will let you know that Louisiana Medicaid, our budget is set up that we have an administrative side to Medicaid and a payment side to Medicaid. So our administrative side is all staffing and operations of Medicaid, and the payment budget is only payments to providers. So the Medicaid budget for our Medicaid vendor payment side is $17.65 billion, and our managed care plans is roughly $9 billion, and I can provide you a breakup. Our Healthy Louisiana plans is 13.5 billion, I'm sorry, with a B, and our dental plan is 282 million, and our coordinated system of care for our the specialized children is 72.6 million. And that is what I have planned to really discuss today, but I'm open to questions.
All right. Thank you, Tara. On your, when you guys expanded, and I'm just looking at slide 2 here, you talked about maybe 750,000 adults were able to qualify for the expansion. Was that, when you guys planned for that, what did you anticipate the number would be?
Our number was much lower than that. We started off around 350 to 380,000, and right after the first year or so, we were up about 425,000, and now today we're up 700 to 750,000. And I can tell you that the Medicaid expansion for these adults, our quality of services, and the number of preventive care that these individuals have received has been life-saving to many.
It's interesting that you have a carve-out for your behavioral health. That's going to be new, or do you already have that?
We already have that now. And I will say, so 90% of our population is in managed care. The majority that's not in managed care is our nursing home and our waiver recipients. But even those individuals that are carved out of managed care receive their behavioral health specialized services through the managed care companies. It's integrated.
Do you use the same managed care company as one of the 5, or is this a different managed MCO?
They are one of the 5. They're the 5, and it'll be the 6th in January.
Is that the same?
For our CSOC kids is Magellan only.
Right. Is that the same with your dental carve-out?
No, our dental carve-out is mainly for children, what Medicaid can cover, and any value-based services that they may offer, and it's through DentaQuest, and MCNA is our 2 MCOs.
And then you commented a couple of times on child and maternal health. I assume that you guys have moved your postpartum, you've extended it beyond the 60 days.
Yes, sir. We were actually the first state on April 1st this year to do that.
And what kind of effects have you seen on maternal mortality post delivery?
Yeah, it's a little too early to discuss, to have our data yet. I actually met with our one of our largest birthing hospitals in Louisiana, and we are starting to just gather that data now. I will say, with the public health emergency and with the maintenance of effort rules, where we can't disenroll anyone unless they pass away or move out of state permanently or request, members could have received, if a pregnant individual became eligible for Medicaid due to their pregnancy, they've actually stayed on Medicaid this whole entire time. So they could have had up to almost 3 years of coverage rather than the 12 months. So I do think it's going to be difficult how to parse that out because of the public health emergency at this point.
All right. I think that's all the questions I have. Do we have any members online with questions? Hearing none, I think we're done. Tara, certainly thank you for sharing the information with us that you did.
All righty. And if you have any follow-ups, please, my email address and Ms. Parker's email address is on the last page. So anyone, feel free to reach out with any other questions. And good luck on y'all's endeavor for reform. We may want to follow your reform and help may see some items that we can maybe implement as well, because there's always innovation and change.
It sounds good. It's always good when you can reach out. We can talk, have the opportunity to talk to other states to sort of see how you built your mousetrap, so to speak. So
Yes, sir.
we certainly appreciate you. Thank you, ma'am.
All right. Thank you.
Thank you.
All right. Bye-bye.
Bye-bye. So So that concludes our hearings for the last 2 days. There'll be another Medicaid hearing December the 1st. The major component of it is we're going to be discussing postpartum. There may be 2 other items I bring in. Those would be, at this stage, obesity and autism. So anyway, we'll have more information coming out. And I probably should have done this yesterday when there was a larger crowd here, but putting these meetings together takes a significant amount of time and requires a lot of effort. And I certainly want to thank Brittany, who's basically my senior policy analysis, for all the effort that she put in. I've got some spreadsheets here that I haven't shared with everybody, but it's basically all the states, everything that they're doing with whether they're MCOs or fee-for-service. Excellent breakdown. I appreciate it. And lastly, and certainly not least, is my committee assistant, Janet. We've worked together for the last 3 years, and she's going to be leaving at the end of the month to enjoy her retirement. It will be a hole here in the Senate. So, Janet, thank you for everything you've done. Appreciate it. Anyway, that's it. Thank you, folks.